Bismillahirrahmanirrahim. Today we have a symposium on the functional recovery of schizophrenia. This is a very strange concept. When we talk about the functional recovery, we want our patient to be absolutely normal and they should be able to live a healthy, happy life. However, in real life situation, this is a very difficult concept and we always have some problems associated with it. So today symposium aims to highlight some of the features related to this concept of functional recovery of schizophrenia. What are the challenges associated with it? My first presenter will be Dr. Mahnoor Irshad, who is a second year psychiatry resident from Department of Psychiatry, Services Institute of Medical Sciences, Lahore. Our second presenter will be Dr. Aafia Malik, who is Assistant Professor of Psychiatry in Department of Psychiatry, Allama Iqbal Medical College, Lahore. And in the end, I will try to elaborate some of the challenges and what needs to be done about it. So our first presenter, Dr. Mahnoor Irshad, please.
Thank you. Assalamu alaikum. So I'm Dr. Mahnoor Irshad, as Dr. Nasar has already introduced me. And now I like to begin with our presentation. So first of all, the disclosure that we have nothing to disclose and there is no conflict of interest. Next, please. Okay, so what are the learning objectives? What are the points that we will be learning and discussing in this presentation? By the end of this session, we shall be able to learn the definitions in functional recovery of schizophrenia, learn the challenges that come along with the functional recovery, and what further is desired to elaborate and improve in the functional recovery of schizophrenia. Next, please. Okay. So when we talk about schizophrenia as a psychiatric illness, for me, it is one of the most feared psychiatric illness among the patients. I was recently listening to a consultant psychiatrist who said something that hit me really hard. And he said that when a layman talks about someone who is crazy, he basically fulfills the criteria of a schizophrenic patient. And I thought that this is actually true. Because to a layman, to a normal person, what is a crazy person? A person who hears voices, a person who has disorganized, bizarre behavior, and a person who has paranoid ideation towards others. So yes, this is what a layman will call someone crazy. So it's really hard to live with features like that in daily life. So these are basically some of the features of schizophrenia that are being included in our introduction that are not the part of a formal diagnostic criteria of this illness. And these include disability in everyday functioning and the everyday living skills, and now the other comorbidities that come along with it. Now, if we see the things historically, for years, the primary focus on schizophrenia was basically on the reduction of the clinical symptoms that are the psychotic symptoms that are the primary core symptoms of this disease. And the other goal that was focused majorly was upon the discharge from the long-term care and on relapse prevention. And this focus clearly does not address the majority of the problems experienced by people with schizophrenia. That is their everyday functionality that is disturbed to a large extent, and that is very debilitating for the patient, both mentally as well as physically. Next, please. Okay. So what is the current focus? So with passing time, different studies and researches are being carried out, and now it is more widely accepted that recovery is possible even to the extent of full absence of all symptoms and disabilities, and that optimal recovery should be a goal for the people with schizophrenia. And this recovery does not involve the absence of the clinical symptoms only. It also talks about the functional recovery of the patient that we were recently talking about in the last slide. Next, please. Okay. Now, the point to focus is that what is the actual definition of recovery? So what is the thing that we should consider as recovery? And there are multiple definitions for that. So recovery is often viewed as a process and not an outcome. So there can be literally dips in that process. When we see patients, the patients show remission and they go back to their daily lives. They do jobs, 9 to 5 p.m. jobs, but then there come relapses and there are dips during this process. So it's a continuous process. It doesn't stop. It goes on and it varies from patient to patient. So this process may involve improvements in different elements of the illness at different time periods. For instance, in the first part of the illness, our main focus is to treat the psychotic symptoms, and they are often responsive early in the course of illness, obviously when we give the psychiatric treatment and medications, while improvements in everyday functioning may take longer to achieve, and it will vary from patient to patient. So that's what we are basically talking about in this presentation. Next, please. Okay, so comorbidities and subjective well-being. Obviously, comorbidities will debilitate the procedure towards the functional recovery. And as we were talking about that, it is a continuous process. And during this process, if comorbidities are faced and if they are already present in the patient, that will definitely hamper the procedure towards the functional recovery. And these comorbidities are important consideration in terms of both prevention as well as the treatment. And some do not develop them until later in the illness course. And subjective well-being is basically a domain that needs to be continuously considered over the course of the illness, and that can only be identified by the patient. So this needs to be communicated and conveyed to the patient and discussed with him that what subjective well-being is to him. And it does not have a clear relationship with all other symptomatic and functional features of this illness. Next, please. Okay, so when we are talking about recovery, what are the different elements of recovery that we should be concerned about? As we already talked, recovery is a continuous process and it includes freedom from troubling psychotic symptoms. Obviously, that is our first short-term goal for the patient. Then we move towards the relapses, satisfaction with life and daily activities. Definitely that will involve at least pre-morbid functioning in the patient and a suitable functioning in everyday life, like the patient can earn for his family. If he's a school-going student, he can be back in his studies and perform the way he used to. All these things come in the element of recovery. And in this symposium, we will focus on the issues associated with functioning and how is functioning defined. Basically, functioning will be defined here as the performance of daily activities that are required for self-maintenance, like earning an income, maintaining a residence, as well as social activities. And especially in lower middle income countries like Pakistan, where there comes a lot of stigma associated with the mental health issues, we see patients with schizophrenia in our daily clinical life. They are married and they are leading lives, so they have families to run, and it can be very debilitating and difficult for them. So these are the elements that we need to consider. Next. Okay. So what are the definitions and terminology for functional recovery? So defining functional recovery can be difficult. The definition of functional recovery can vary from person to person, and every person's perception can be different for that. So there are no clear standards for suitable levels of accomplishment. But just for a simple understanding, what we mean by functional recovery is that absence of disease or functional outcomes, such as living independently, generally symptom-free, but have no productive activities or social contact and are satisfied with the situation. Now, here is a tricky thing. When we say the patient is generally symptom-free, but he doesn't have any productive activities or social contact, we need to see whether it is the point where functional recovery is achieved or not? Probably one will say not. So this is why recovery is a continuous process, and we have to work for the best of the patient, where he achieves actually a state where he can contribute to his well-being, his family's well-being, and ultimately the society's well-being. So the individual's history and motivations and the value judgments all play an important part over here. Next, please. Okay, so basically, cognitive performances are, as they are affected in schizophrenia, what are the things that we need to consider during this process of functional recovery that can help better the cognitive performances? These betterment of cognitive performances can fall under 5 levels. They can be treatment-related betterment of the cognitive performances, that is during the first phase of the illness, and then the demographic profiles of the patient can play an important part. The demographic profiles of patients, especially in lower middle income countries, is a plus point in my view, as they have a strong family support system as compared to other parts of the world. So it can help better the cognitive performances during the process of functional recovery. And then residential independence, vocational outcomes, and social functioning are the other elements that need to be worked upon. Next, please. Okay, so when we talk about remission of the clinical symptoms, first of all, we need to know what are the clinical symptoms. They are the acute psychotic symptoms that present during a relapse or maybe during the first episode of schizophrenia, that are the hallucinations, delusions, disorganized behavior, disorganized speech. So that is basically the active phase of the illness. And for remission of clinical symptoms to occur, basically as proved by the DSM, the Diagnostic and Statistical Manual of Diseases, for remission of clinical symptoms to occur, the clinical symptoms should not be present, like the delusions and hallucinations should not be present in the patient, and if present, they should be present to a mild extent. And when we talk about the temporal duration of remission, so at least 6 months duration should have passed for the clinical symptoms to be absent. So that's when we will say that the clinical symptoms have remitted and the patient is in remission and he is on the process towards recovery. Next, please. Okay, so when we talk about functional remission, there are multiple challenges in defining this. As we, first of all, we already talked about the definition, that what is the actual definition that we have to work upon. And these are the things that we need to consider for our future practices and for our patients' well-being. So the duration, the symptoms, to what extent the symptoms have remitted, to what extent the symptoms have improved. These are the things that we need to consider in the process of functional remission. The wide-ranging normality, whether the recovery is full or still there are some mild symptoms present that can lead to minimal impairment. So the process of this recovery can be different for every patient. Certain patients can perform well, extremely well, and no one can tell, even if he is on medication and he is a schizophrenic patient. And then there will be patients who will be having minimal impairment, but that's okay, because that varies from patient to patient. And this is the concept we need to understand, and we need to grasp this. So next, please. So till here, I have talked about the importance, the definition of the functional remission, and now we need to see, is functional remission a tenable concept or not? For this, I like to invite Dr. Aafia Malik to continue and take over. Over to you, Dr. Aafia.
Okay. Hello, everyone. I'm Dr. Aafia Malik, as my worthy colleague has introduced me. Today, we are talking about the functional remission. She beautifully explained that functional remission is a process, and we cannot say that it's a thing which ended at once, and we cannot comment that these things are identifiable, and we can categorize them very accurately. If there is a very you can say hazy areas there where we have to talk about. With my presentation, I want to put a few questions in our mind, that being psychiatrist, where is the gray area and how we can define functional remission. And with this presentation, I want to try to make you think on this, that which areas should be considerate and focus on. So coming again towards that, is functional remission a tenable concept, is a concept, is it justifiable to talk about it? You know that when a patient is having schizophrenia, the characteristics are always cyclic. You cannot say that after 6 months the whole of the symptoms will be resolved, or you cannot measure that how many symptoms and at what extent the symptoms will be resolved. Regarding cognitions, my colleague was talking about the cognitive functions and its disability also vary. Regarding social, educational, or vocational milestones, you can also cannot comment that what type of and to what extent the functional remission you can get. So is this justifiable to ask about that, the functional remission, how much is the remission is going on and till what time it will occur? Well, here I want to discuss in my daily clinical practice, we see so many patients with schizophrenia. When you have a patient who is taking a good education, you can, if you have a patient with a medical background, you can say if a medical student come to you and he's newly diagnosed with schizophrenia or schizophreniform, do you think that when the positive symptoms and the negative symptoms are being resolved, would he be able to complete his education as a medical student? Or if even if he completed his education, do you think that his emotional IQ, his performance will be the same as that of the premorbid level? So where you are defining the functional remission is there. Are you defining it on the basis of social domains? Are you defining it on the basis of educational domain? Or you are making some other milestones for it? So these are the questions which are coming in my mind, and I want you people to think on it. So coming towards the poor premorbid functioning, are we able to make a temporal relationship on it? That when these symptoms occur, whether when we saw or the family identify the symptoms or the characteristics, was that a prodrome period, or whether it was the premorbid condition? Are we able to differentiate? I think this is very hard for us, because on the history basis, you cannot get the proper information. Sometimes family is not understanding that. They are thinking that the pattern is according to the personality, and there are so many details on it. So coming toward the treatment response, with every patient, you know, the treatment response is different for every human being, every individual. So are we defining functional recovery on it, or the functional decline? So this slide is all about that. Next, please. Yeah. Okay, so coming toward the question now, if we assume that the functional remission is a tenable concept, do you think that negative symptoms or the other symptoms which are coming which we are considering in functional recovery, are they constant or they are dynamic in nature? Definitely they are dynamic. You cannot measure them on an accurate scale. So we cannot say that is it justifiable to measure them on the basis of negative symptoms? That if I can explain you with an example, that in the patients with schizophrenia, where you are saying that he is in functional remission when his negative symptoms are improved, or he is socially performing well, or if his family is satisfied with the treatment, where is the criteria and what we are considering? So this is all about. Please, next. So what domains of functioning should be considered? There are so many areas which we should focus, that how we can define or we can work on functioning. East versus West, there are many differences in the culture, in the race, in the genetics. So you cannot compare both of them, as in the East they should be different, and in the West should be different. Coming towards the productive activities, in the lower income countries, lower middle income countries, the productive activities are identified by the functioning of the patient, who is patient or individual who is financially helping his family, who is performing his social responsibilities, whose education is going on a you can say on an average level or more than that. So these are the productive activities. But in the West, there are the different terms that you can say that they define the productive activities. So this is also another domain we should consider about considering the residential and self-maintenance activities. This is also an important domain. What about the social relationships? Do you think that if a person is having schizophrenia, would he be able to maintain his relationship with the partner, like in his married life or with his family members? Is he on the pre-morbid standard? This is another question. And in your clinical practice, you can see that these relationships are always affected, but in most of the cases, they are affected. So this we should also consider them in functioning. Okay, what about adherence of the medication? When the person is using medication for a 1 year or more than 1 year, and he is on in a remission pattern, the positive symptoms are being addressed, family is considering that the patient is well, what they are start doing is start skipping the medication, and adherence is not that proper. So functioning can also be affected with this if the adherence is not proper. Reduced risk of for relapse, this is also important. We need to see all those factors which can make relapse possible. So readmission or emergency care, it should be considered. So please, next slide, please. Okay, coming toward the social and the familial roles, they are very important in our functional recovery. If the patient is good at homemaking versus outside employment, that he's here I want to discuss about the biopsychosocial model, which is core, and you can say the basics of our of psychiatry. If the person is performing well and having so the positive symptoms are being solved and the negative symptoms are also in remission, if he is performing his homemaking responsibilities well and his employment is also going well, then we can consider that yes, it's in somewhat in a social recovery, social remission. Coming towards the poor organizational abilities, this is also another thing to ponder, that if the person is not performing well in an organized manner, or if he's not working properly in the organization, that it could also lead to the relapse and poor functional remission. Next, please. Okay, so what is the role of our efforts, and where we should force the person, or we should consider that person or the patient should work upon? We should be able him to attend rehabilitation clinics. We should support him in receiving individual or group treatment. There should be attempts to apply the skills which he is learning. He should attempt for applying it, and there should be an interest in learning these skills. And we should be able to make him willing to have attempt to perform these skills. Okay, next. So what should be the first step for the patient when, as I told that in what domains we should put effort for? So first step what the patient should take is the learning new skills. When a person is learning new skill, there are many critical areas which he came across, and whenever we have to pass through exams or some important things, there's always a failure can come, and for that purpose we should support the patient, and we should motivate him on try again, and we should explain him that try and fail is better than never to try at all. So I hope this is clear to everyone, that we should be very motivating every time to our patient, and this is very important for the social remission of the patient. So what should be the solutions? The level of success within the functional domains, or the breadth of the success across the functional domain. Here's also, there is a point for thinking that what is the level of success for you, whether it is within the functional domains, or you think that different functional domains should be the function in different domains is successful then you can think upon that whether, I'm sorry if I'm not clear on this. I'm talking about whether you are considering a one functional domain and its success, or you are taking whole of the domain together and taking their success as a whole. So we need to think that what we are considering. Next, please. The things which I was talking about, I want everything to be on a good scale. And I think that was too hypothetical to be true. We cannot force a patient and we cannot motivate him all the time that he can try again, again, and again. The family can get fed up. The patient can get fed up. They can mess up with the things if he's not understanding, because as we know that the cognitive functions are also being compromised. So how many times he need to repeat and he had to face the failure? So this, if he is facing the failure again and again, it can change to continued fail attempt, which could be toxic for the patient. So we also need to consider to till what point we need to force the patient and to what extent we need to motivate the patient. So the things are hypothetical, but at least we can work on them to improve the functional remission. Okay, so progress as an index, we are trying to clear them into criterions that what we are following. For development of functional remission is the level of success that is obtained, or breadth of the success across domains, with the domain defined as social, productive, activities, and independent living. Again, I'm going to say the which I was explaining on the last slide, whether we are taking one domain and its success, or we are taking whole of the domains and their success. So this is two criterions which we can follow. What level of functioning is consistent with remission? Healthy range. Variability in the extent to which individual functional goals are met. Marked variation in social activities across individuals. Here, I'm going to hand over my presentation to Dr. Khan. So please continue and explain further. Thank you.
Thank you very much, both of you. It was nice to hear. And then I want to build up on the same parameters. When we talk about health, it's a wide concept. And the definition of the health changed over the periods of few decades. So initially back in 60s, when we were talking about the health, it was only the physical health. Then later on, the mental health component was added into that concept. And then afterwards, some psychological component was added. Then spiritual component was added. There are now at least 6 to 7 different domains where the definition of the health is based. And we are still having evolution into that. So I don't know what will happen in few years. Maybe we will have about 10, 12, 15 parameters for the definition of health. It's evolving. And if we consider what has been said in these presentations, in the previous two presentations, I will summarize this in a very small way. Let me explain to you. And I'm sure that all of you must be having these clinical experiences in your day-to-day life. I had a patient who was a young female. She was 19 years of age when she developed the psychotic breakdown and had all positive symptoms of schizophrenia. She was having aggressive, violent behavior. She was paranoid, and things were complicated. We started treating her. She was in remission as far as the clinical symptoms were concerned after a year's time. And when she was in remission, she came to me and saw me in my clinic. And I was myself devastated with the type of the questions she was asking. So the first question she asked, "Doctor, for how long I've been sick?" I said, "Well, you have to tell me, or you have to ask your family, because I don't know precisely when exactly you started having the symptoms of psychosis." And then the second question she asked, "If you are not able to tell me, this means that I was studying in third year of my high school, university, when I felt that I was in hospital. So maybe I was sick for more than that. Maybe I was sick at the first year level because my friends started isolating me. I was losing friends. I am not having any social contacts, and things started getting jeopardized. And now next question was more trickier. Most of my friends are married. They have babies and they have their families. What about me? That was the turning point. And I started asking me, even if my patient gets recovered, what will happen to their lives? They are compromised, and started working on the functional remission of schizophrenia. As I mentioned to you, the healthy range is variable. Some of the population people, they become teachers. Some of us become doctors. Some of us become engineers. Lots of them are having other jobs. So what is normal for an individual? Having a job, a stable job, a professional job, or just a labor job? What? And this is so much variable. And when it is applied to our population who's suffering from schizophrenia, do we really feel that those people can be as successful as the benchmark could be engineer, a benchmark could be a doctor, or benchmark could be something else? Now, where to start it? Where to make sure that these people are healthy? They are in functional remission. That question remains unanswered. And I will try to explain it to you, further concepts related to it. So there is a marked variation in individuals' life. There are people who are very social. They have so many friends. They interact with people. They party, they enjoy life. They have drugs, alcohol, and other activities. But there are people who just prefer to stay home. They want to love having some maybe cooking, maybe just watching TV. Do we call them abnormals? So in functional recovery of schizophrenia, these concepts will further complicate our definitions. Now, pre-morbid functioning versus the prodrome. As I mentioned to you about that lady, that girl who came to me in the clinic and asked me when precisely my psychosis started, and I had no clue. I cannot depend on the retrospective recall. I cannot depend precisely on the family's account, and I cannot depend on even my own judgment when I'm seeing the patient for the first time. So pre-morbid functioning is intuitively appealing and easy to reference as a benchmark. But where the pre-morbid ends and where the prodrome comes in, that's a tricky situation. So in prodrome, we all as psychiatrists know that there are symptoms which are very much marked, which are very much there, which we feel that shows us that there is a clear-cut demarcation from and deviation from normalcy. But do we consider the pre-morbid and pre-drome to be different states or one state? And how do we go back and assess that this person is now actually at a pre-morbid level? Question. And it's always intrigued me. Variation across lifespan. And I'm sure that all of you psychiatrists have seen this. A patient coming as a young, having 7 teenagers, maybe 19, 20, suffering from schizophrenia, presenting with the same symptoms, but having multiple psychological, social, and other adjustment issues. A person who is around the age of 40 may be symptom-free, but is he adjusted well? So healthy real-world functioning is also intrinsically developmental with marked differences in expectations for individuals in their teenagers when the illness often develops and early to middlehood. So if a person with schizophrenia around the age of 40 had about say, 2 relapses in the life, and very much compliant with the medication, what is recovery to him? And what is recovery for a person who is 21 years of age, lost 2 years of his life in this illness, and now started going back to the college? That comparison of 2 ages at the various lifespans would be different from individual to individual, from culture to culture, from social aspects and other parameters. Topographically, of everyday living skills is dynamic, as Dr. Malik mentioned. Now, is it a tenable concept? As Dr. Mahnoor mentioned, what should we define and how should we define an independent real-world functioning other than academic performance in adolescence is intrinsically more limited than in adulthood. So all of these things, all of these parameters make things, measurable things, more complicated. So the definition gets complicated as well. Achievement is productive, residential, and social domains, occurs to a greater or a lesser degree in a healthy population. So if I have 5 kids, one of them maybe would be able to be a doctor, and the 4th one maybe wants to be a painter. He don't want to do anything. He wants to stay home and just draw. And he'll be living fine and healthy and happy as well by drawing the pictures, selling the portraits, making money out of it. When we talk about Van Gogh, when we talk about Picasso, what are we thinking? Those people were having problems in their lives, but they were functional. They were able to produce some pieces of art and other things, which are still probably the best of the bests for centuries. But do we know that one of them was suffering from psychotic illness? Probably yes, probably no. But that degree of severity of illness, the compromises in the social life, to define the breadth of the success from one domain across the horizon, to make sure that he's happy with the wife, he's having good relationship with the kids, he's happy and comfortable with the bosses are comfortable with him, the colleagues are happy with him, and the friends are also comfortable in his presence. When we treat a patient with schizophrenia, do we believe that our patients, when they go back to their friends, they accept him as they were, or they will accept him with the change of mind and change of emotions? Complicated. And that is what makes it further difficult in defining the functional remission. Achievement of some level of success across some combination of functional domains. Exactly which breadth of achievement and at what level of achievement is the question to be answered in terms of defining functional remission, which is always complicated for me. Practicing psychiatry for more than 30 years, and I'm still confused about my own profession, about my own domains, about my own patients. Why is that? Why there is not a standardized solution for everything, like cardiology, like gastroenterology, like hepatology? We are still fluid. We are still thinking. We are still imagining what exactly, precisely is important. Again, here I will quote another patient of mine. So my daughter was getting operated. She had a surgery. And when we were waiting in the waiting area, pre-operative waiting area, I saw one doctor coming into the operation theater and passing us and then going into the operation theater. And I recognized that gentleman. Oh, I treated this gentleman for schizophrenia about 5 years ago, and he is here. He never tried to have met my gaze, and he was again just passing on. And I was just thinking, what is he doing here? And then realized that was the anesthetist for my daughter's surgery. And he gave anesthesia to my daughter's surgery. And she recovered and she is fine. But imagine those few hours as a psychiatrist I was having outside the operation theater, when I know that the person who was giving anesthesia to my daughter was having schizophrenia. This is unfortunately a dilemma. I am sharing my own views and thoughts, but I believe that this is the dilemma. A level and breadth approach to defining functional remission is complicated. Dr. Malik gave two criteria, criteria 1 and criteria 2. The criteria 1, she mentioned that level of accomplishment, no actively working towards change, functional improvement, making attempts, no real world success, attending vocational training, rehabilitation without employment, function in the locked board, and care attends social activities without participating. So these people are trying to put the efforts. They're attending the rehabilitation centers. They are trying to find a job, but still they are trying to find a residence, but they're still not considered as functional. And that again, I'm again confused. When these people start working in the social groups, they have partial success, non-supported staffed residents part-time. So lots of patients, they start living independently. Lots of patients, they go back to their family. They start having their families as well. They produce children as well. They are considered to be having remission as well. But we still consider them to be functional? That is unfortunately still needs to be defined. And in criteria 2, when breadth and accomplishment of the functional domain is achieved, making a progress in a domain 1, partial success in one domain and making progress in 2, or full success in domain 1 and making progress in the 2 others. So where is the recovery? And when we put the patients into these various blocks, that's too much of saturated slide. But if I put patients into various slots, I will feel that full success in 3 domains is simply unimaginable. Maybe I'm wrong, maybe I'm too pessimistic, but in real life situation, this is how things are. And we have to rethink about functional recovery and its definition. Now, what is the time frame used for the index remission? This is another question. Usually when patient comes to me, and we all as psychiatrists, we tell the patient that you'll be okay. There are chances of full recovery in majority of the patients. They go back to their normal lives. They are working well. They are functioning well. Is it really so? How much is the time period? Do we have to give them 3 months, 6 months, 1 year, 5 years, 10 years? If you give them a time period of a year, 6 months of the illness, 6 months of the treatment, and 6 months of the rehabilitation, 1.5 years, what do you think? If we waste 1.5 years of our life, where will we be at some point? A 6-month duration of remission is likely capturing maintenance of clinical symptomatic improvement. In contrast, many functional goals in the real world require substantially longer time period to occur, and evaluation of maintenance might require an even longer time period for observation. So it may be 5 years. And if it is really 5 years, imagine yourself into that situation, having some disease and losing your life, 5 years of your life. And I have given you 2 examples. Imagine, just think about it, and then decide, where are we standing? There are environmental issues. So there are families who are very well supporting. So they try to feed the patient, take care of their hygiene, give them good clothes, good warm house, everything is good. But there are people who unfortunately don't have those supports. they have to live on the social pensions or some way of living and surviving. Majority of them falls into this category where unfortunately the support system is compromised. Financial compensation and health insurance, it's variable. In some countries, the health covers psychosis and they give the benefits. In some countries, there is no insurance, and in some countries, there is partial insurance. How will we address this issue? Why can't this be across the globe the same? Societal factors, including stigma. As I mentioned to you, if I'm going back after 3 years of suffering from an illness, will my friend accept me the same as I was, or will there be a difference? Tricky. So independence in residential status, marital status, and employment. These are the three main issues, main domains. Consider how many people suffering from schizophrenia on psychotropics have good marital life. Now, when I say good marital life, I don't have a gauge to assess it. But when I talk to wives and then I feel their responses for the marital life, I'm always again confused. Employment. Most of these people do get unemployment. They do have a stable employment where they work from 9 to 5 days a week, which is a good amount of hours, and they earn as well. But do you feel that the employer is comfortable with their success stories? How many success stories as a psychiatrist we hear in everyday life from a patient who's suffering from schizophrenia? Question. So critical to consider, real world functioning objectively measured and subjective responses to life situation, including treatment as separate components of recovery process. So I propose that functional remission as a separate domain of functioning from clinical remission and subjective response, and argue that the process of recovery includes all of these domains. It is more challenging in the domain of functional remission than clinical remission to identify the levels of performance that would be clearly remitted. But we have proposed that both level and the breadth of accomplishment should be considered, and that the time frame for sustained functional remission be similar to that for clinical remission, probably 6 months, ideally. In conclusion, I will say both external and internal factors other than ability can affect real-world outcomes. And we are likely to reduce the changes for functional remission, even in people who have the necessary skills to achieve these milestones. We suggest assessment of patients that separate ability from real-world outcome in order that other factors can be considered, but also believe that functional remission should be indexed to real-world outcomes and evaluated accordingly. So in summary, I will say that as psychiatrists, when we start seeing the people suffering from schizophrenia, acute psychotic episode, we should start thinking of long-term, and we should start utilizing other sources for functional recovery, which can make us a little bit more successful than what we are these days. I am very thankful for all of you to listening to us. I will go back to Dr. Malik and Dr. Mahnoor to say a few words, and then we will end up the session. Dr. Malik.
Yeah, thank you so much for listening. I just want to put few points so that we can establish these things in our daily clinical practice, and we can convey this knowledge to our juniors so that they also think and consider the clinical recovery along with the functional recovery. They both need to be addressed at the same time. Thank you so much, and over to Dr. Mahnoor.
Okay. So thank you so much for listening to us. It was really a pleasure to talk over here on this platform. And as my both colleagues also mentioned the importance of the functional recovery in schizophrenia. So I think that this discussion will pave future pathways to consider functional recovery as a very important process of the recovery road of schizophrenia. Thank you.
Thank you very much, everyone. If there are any questions, we'll be here to respond to them. We'll be joining you live as well. This is a recording, but we'll come back. Thank you very much, everyone.